So once we identified our team members, it was important for us to identify the target population, meaning those individuals who were in the eligible age group, as well as any high-risk individuals that may also need to be screened. And so our first focus was identifying the target population. Next, we had to decide on the screening strategy, meaning were we going to try to get patients in primarily for colonoscopy, or was there another approach we wanted to go with? Because of our location in regards to the city of New Orleans and access to colonoscopy, we realized that the colonoscopy approach wasn't the best option for us. The closest endoscopist was probably about 20 minutes away from our facility, and it required patients crossing over what's called the high-rise bridge here in New Orleans, which is a bridge that's about a mile, 1.2 miles high, and it was about a mile long. And so most patients are very fearful of crossing that bridge. The patients who live out in New Orleans East, that bridge has served as a barrier in itself. They don't want to come into the city unless they absolutely have to, particularly the older population, those who are eligible for screening, 50 and older. They really hate going across that bridge. And so in order to schedule them for a colonoscopy, we had to take in consideration how many of our patients were willing to go across the bridge to have that colonoscopy done. So for us, we knew that wasn't probably the best approach, so we opted to go with the stool-based option, which could be more convenient. It was able to be done at home, didn't require a bowel prep ahead of time. And we thought it was a very simple procedure for patients to complete and bring back to the office. So we looked to hire a patient navigator or care coordinator. Initially, I thought it was best to have someone with medical background. So I was looking for a medical office assistant, LPN, RN, but in our experience, our best navigator was a lay health worker. So it really didn't have a lot of medical background, but had background working with the community. And so my recommendation would be find someone who has good people skill, has the ability to build trust and empathy with the patient, and also know how to get patients, move them to action. This past hurricane season was probably one of the worst hurricanes we've had since Katrina. And as a result of that, 2 of our providers ended up resigning. And one of the things that's important about our community is that we serve as a trilingual community. A third of our patients speak Vietnamese, a third speak Spanish, and the other third are African Americans. And so at the time, we had 3 Vietnamese-speaking primary care providers, which was awesome. We loved that, right? And our community loved that, right? Because they had providers that spoke their language that they can relate to. We had male and female. And so it really was part of the success of us reaching our 80% in our screening rate, is that we had providers that patients could relate to, and that the provider could actually speak their language and kind of encourage them. We had lay health workers that were able to fulfill that role, and for us, it made all the difference. We started off with the medical office assistant. We did have some improvement in our screening rates, but when we brought in the lay health worker who had a real true connection with the community, where patients knew her personally and they felt really fond about her work in the community, when she recommended they go for screening, they did it. They didn't question it. She was able to answer their questions if they had any concerns about it. And that made all the difference. We saw about a 20 to 30% increase in our screening rate just by bringing in the right patient navigator and care coordinator. So my advice would always be find someone in the community that patients will respond to. And if you don't have that, then find an individual that can connect with patients. Just know how to get them to warm up, to open up to them, to feel comfortable with them enough that they will agree to their recommendations. So the most important component in the planning phase is having a solution for colonoscopy or access to colonoscopy. When having the discussion with your providers, they're going to want to know where are we going to send patients for colonoscopy, particularly if they have abnormal fits, or if you just feel this person has a high risk, family history of colon cancer. Where are we going to send them for colonoscopies? And so if you don't have that question answered, most providers will be slow to get on board. So for us, we had to identify how we're going to get patients in for colonoscopy, where we could refer them, and understand the steps in that process. So once we had that ironed out and we was able to have that discussion with our providers and they felt comfortable with that solution, talking to them about our plan and our strategy was a little bit easier for them to accept. Some of the key things that we've learned through our process, For me, I would always say it's not easy. And so the first myth in the process that it's easy, that you can just show your providers the data and either data shame them or just, kind of convict them that they're not doing well and let them take it from there. And what we understand is that that doesn't work. You may get a 5 or 10% increase, but to have significant increase in screening numbers, you have to invest resources into the screening. The planning committee, whether it's the administrative staff or the medical director, really has to think in a population sense of how do we move our population of patients forward in screening. For us, that was about 800 to 900 patients. So to think, how do we get 900 patients screened for colorectal cancer? Thinking that it's easy was what caused us to have some delay. When we really realized that we weren't getting anywhere by just talking to our providers about it, showing them the data month after month, is when we started thinking carefully about more of the steps of the process. Bringing in the QI director, having a patient navigator on board, tracking how many fits we were handing out, tracking how quickly they were being returned, having someone meeting with the patient to find out why they weren't returning the fits on time. So there are multiple steps in the process that often get overlooked in the beginning. So I would say first step is not going to be easy. You do have to think through each step of the process and make sure you have a plan for that. The second step is patient adherence. Understanding your patient population and understanding that the best test is the one that gets completed. And that sometimes is, it takes a while for providers to accept that. Most providers want to just offer a colonoscopy because it's easy. It's easy for them to write the order for it. If the patient can complete the colonoscopy, it satisfies that measure for 10 years. The problem is there's so many steps involved from writing that order to actually having a completed colonoscopy with results in the chart that it causes a delay in increasing the screening rates. And so patient adherence is probably the most challenging aspect of the screening. Whether you're doing stool-based screening or colonoscopy, patient adherence is always going to be the challenge. And so those are the two things that need to be taken in consideration and thought through in the onset of your program. It's important that everyone thinks about the process as if they're thinking through changing behavior, right? And so there's a concept in psychology called stages of change, and where you look and you think about when someone has an unhealthy behavior that they're trying to change, like smoking or alcohol use, there's these steps that the patient has to go through, from like a pre-contemplation to contemplation to action, and then maintenance, and then there's relapse. And so I bring that up because every aspect of the screening process involves some form of behavioral change. In the beginning, the behavioral change comes from those involved in developing the plan. You have to think differently about your approach to screening. You have to think differently about how you're going to address this with your population. So some of the strategy we talked about before, you have to think about how large is your population? What strategy will work best for our population? And so realizing that it's not going to be a quick solution, right? So I think for most administrators, CMOs, they like to think that it's going to be a quick process. You just show the providers the data. Once they see the data, they see their performance, they're going to be motivated by the data alone to improve it. That's not going to be enough. The CMO, your quality improvement team, they have to come up with a population health strategy that encompasses everyone. Every eligible patient needs to have an option for being screened. For the providers, they have to change their thinking about what tests they're going to recommend for screening. You can't just think colonoscopy. We talked about that a few minutes ago. You can't just think colonoscopy because that's not going to address your whole population. So you have to rethink your mindset and your strategy on how you're going to address your population. You also have to understand that it's going to be more than one conversation. So even though you have a conversation with your patient today and that patient may not be ready, that doesn't mean you don't bring it up again in 2 months or 3 months. When you're addressing someone who has a problem smoking, you don't just bring it up once and they say, I'm not ready, to quit, and you stop talking about it. You bring it up again, later on, whether it's 6 months from now, whether it's later on that year. Same thing with colorectal cancer screening. The patient may not want to talk about it the first time, so you have to come back again. You can't just let that first time be the only time you bring it up and then document they're not interested, let's move on. The patient, they're not thinking about it because there's nothing sexy about it. They don't want to think about cancer. They don't want to think about their colon. They don't want to think about putting anything in their colon. They don't want to think about messing with their stool. They don't want to think about it. And so in order to get them to complete a screening, they have to change their mindset. They have to change their behavior and their thought process when it comes to cancer screening, and realize that this is a cancer that is killing all of us, Americans. It's the second leading cause of cancer death in the US. And so you have to think about it. You don't want the time to think about it be when someone you know has been diagnosed. It's really important for the CMOs and their QI team to really help their providers to think more of take a population health approach to their screening. And one of the new things that's coming out very soon that's getting a lot of interest is blood-based testing. So we're thinking probably by the end of the year, there's going to be more studies out on blood-based testing for screening and how that compares to FIT and this new stool DNA test. So we're looking at any option that will allow our patients to some space or time in between testing. We feel like that's going to be very effective for them to help them be more adherent to screening, and also more effective for us to maintain a high level of screening over time.